Good morning, everybody. It's a pleasure speaking after such experienced surgeons. I'll give another perspective about what do we really learn more from the CREST study. A lot of you are aware, but it was a prospective multicenter randomized trial which compared stenting and endarterectomy in both symptomatic and asymptomatic patients with largely North American centers. The good thing was there was rigorous credentialing for the stenting operators. This one thing which set it apart from the previous trials. And the criteria for symptomatic were like more than 50% by invasive and more than 70% by non-invasive, and was 60% asymptomatic were more than 60% by DSA and more than 70 or 80 by ultrasound or CT or MRI. Now, the primary endpoints were any clinical stroke, MIs or death. Now, this is interesting. They include MI as one of the primary endpoints, and post-procedure any peri-procedure events plus ipsilateral stroke up to 4 years, they monitor for the effectivity of this procedure. So what was the outcome of the CREST? I think most of you know the results overall were largely the same. If you're talking about peri-procedural outcome of death, stroke, and MI, it was by and large stenting 7.2, CA 6.8, no significant difference. It was largely the same. But when we went through it, the differences come up. Peri-procedural CVAs were overall 4.1 in stenting versus 2.3 in endarterectomy. It was clearly more. While MI were more than 2% in endarterectomy versus 1% stenting. So there were more strokes in stenting arm and more MI in the surgery arm. But good thing was the major CV or major stroke rate was less than 1% in both. So there was no difference. The major stroke, mainly the minor strokes in which were more in the stenting arm. Cranial palsies were more in the endarterectomy arm. And on the follow-up of less than equal to 4 years, it was the follow-up CVA in the territory was 2%, again the same. So effectivity was largely the same, and this is the follow-up time, and you can see the event rate largely was the same over the longer-term follow-up. So, and these are the more results which has come in after 2 years. The restenosis rate, again, has been the same in both arms, around 6% or so. And what they have found that female sex, diabetes, dyslipidemia were independent predictors. Interestingly, smoking predicted an increased rate of restenosis after endarterectomy, but not after stenting. So this was some interesting finding out of it. Now, what do we take it from there? What all we have learned? Now, there have been a huge controversy, and we have been fighting a battle. We thought 5 years back we had won it, but last few trials, there were many trials, mainly in Europe, which showed EVA-3S trials, SPACE trial, and ICSS trials. And all three, by and large, showed that there were more complication rate in the stenting arm, and that started a huge trend against the endovascular treatment in this disease. Then how come the CREST trial has shown significantly different results? So just to compare what is my take and what has been the real reason behind this discrepancy in the results are, first of all, the CREST trial clearly had the largest number of patients than these previous trials. Secondly, a lot of these trials, number of centers were also much more in the CREST. So it was much more widely represented, well-conducted trial, and was the only trial which had a lead-in or a training phase where they really judged whether the operators were good enough to do these procedures or not. Stenting to me, neurointervention is a very straightforward procedure as compared to aneurysm coiling or brain avians, which we do. But it still remains, to me, one of these unpredictable procedures. So unless you are properly trained, while it seems simple and forward to do, you can have complications. So clearly, this was the only trial with largest number of patients and the centers and a proper training phase. And the interesting part, what was the endovascular experience required in some of these previous trials? To me, if you ask me as an interventionist, it's absolutely shocking that in EVA-3S trial, more than 12 stenting somebody had done. Or if you had done more than 5 carotid artery stentings with 30 other supraortic trunk stents, you were eligible. To me, that is no way eligible. 5 procedures or 12 procedures and you're considered as an expert, to me is surprising. SPACE trials should have some reasonable criteria, but again in ICSS, again, 50 overall cases, more than 10 cases of carotid artery stenting which you had done, you were included in the trial. So this was probably one of the factors which played a role in bad outcomes in these previous trials. And this other thing was cerebral protection device. As we mentioned previous speakers, in US they don't reimburse you if you don't use a protection device. While in some of these trials it was not a necessity. In fact, in SPACE trial, only 27% of patients they used it, and ICSS 72%. In fact, one of the trials, it wasn't a criteria that you need to use it. In between the trial, they decided that we should start using them. And a lot of people learned in the trial how to use them, and then we are counting them as the final results. To me, again, that is very surprising. So this is the same. And another thing was MI. It has been hugely controversial that MI was used as an endpoint in CREST, while not in the other trials. So should we really, is it important? Like there's a lot of debate, is silent MI is worse than a stroke? Of course, minor stroke, it sounds much more worse than a silent MI, but there is data, and these are paper published, that patients after silent MI documented this, and they have long-term or worse outcomes and significant morbidity and mortality. And this is what I had talked to you about the operator experience in the previous trials, that EVA3S trial, it was poor, SPACE trial was still adequate, ICES trial, again, only 10 overall strength. So one thing we have learned from the CREST is, even when carotid artery stenting to us, as I mentioned, is a very straightforward procedure, your experience counts. It's not that if you can place a stent anywhere, you can place a stent in carotid and get away with it. Brain is very unforgiving. Minor embolism is very common. When I see some of my cardiologists doing peripheral intervention, it looks so much more at ease, because in brain we know your vessels may look normal, but minor embolism, you may have a symptom. So I think adequate training is one thing we have learned from CREST is absolutely essential if you want to do these procedures. Now the question which I raised, minor stroke versus MI. Clearly what it showed that at 6 months, if minor stroke, the patients, it didn't make a difference. Most of them had recovered. It was the same at 6 months. So most patients with minor strokes recover. But what are MIs? But if you see, this is the long-term follow-up, that patients in the green line shows the MI, they had a significant higher mortality and the longer follow-up. So silent MI is not a benign thing. While stroke, minor stroke, patients do recover. So we cannot really say, oh no, you should not have counted MIs, and look, these patients have got minor strokes. What about cranial nerve injuries? This was not included as primary endpoints. And this is to me, again, because I belong to the neuro circles, I'm a neurointerventionist, to me cranial nerve injury is a neurological injury. It is as bad as a stroke. And this is important because what they found in the CREST, for the 80% of cranial nerve injuries, they had a motor deficit, and 2% of the patients, it was unresolved at 6 months. To me, again, surprising. To us, it is a stroke. It is a neurological deficit which you have. And again, stenting had less access site complications, while a significant number of endarterectomy patients need a hematoma. And again, the experience counts, and within the CREST trial also they found that the complication rate declined over the time and became less of a time, and significantly, at least the major strokes or death rate clearly declined remarkably in the later phase. Again, even when it's a relatively straightforward procedure for us, the experience counts. And so where do we stand here? So FDA approved it in 2011 for standard risk patients, and to us, in neuroscience and formulated guidelines, these were published in Stroke Journal in 2011, which included all these societies, and which mentioned that carotid stenting is an alternative for endarterectomy in symptomatic patients, for the risk to be less than 6%. So where do we stand today? What have we really learned from CREST is, it was the largest and most rigorous trial, we have to understand that. European trials, to me, there was severe lacunae. I mean, not using protection devices, inadequate experience. Learning to use protection device in the trial, to me, is absolutely amazing. CREST means overall they are the same, but there are more minor strokes in stenting, more MIs and endarterectomy. So today, if I see a patient with tortuous crooked anatomy, diffuse disease, we know these are the patients who will have minor embolism, better to send to surgery, while more MIs and endarterectomy means any cardiac issues which we is well established, we should do stenting. But good thing is overall stroke rate, major stroke is RAIM in both the arms is less than 1%. Long term, there is no difference. Sub-analysis has told us minor strokes recover, and MI is not benign. We cannot ignore that. Cranial nerve injuries are again not benign. We cannot really ignore them. And again, learning curves, as I mentioned again and again, remains important, and stenting results get better during the trial period. So I think we should have all these perspectives in our mind when we discuss, these two options in treatment of these patients. Thank you.
Okay, this is a nice paper, good presentation. One thing I would like to say about this is the experience. Number one is the experience. Experience not only in stenting for 5 or 10 cases, but includes the angiography training of the carotids, which is not always easy. Okay, and again the experience. Okay, I come from a school where Klaus Matthias was there. That is the father of carotid artery intervention from Dortmund. And Delhiites know that during 80s I used to do your routine carotid angiograms for your neurosurgeons. And I believe in it that the experience not only in stenting, but before that also the routine carotid angiogram, which can be done quickly and till one has reached that, and at least 100 to 150 angiograms have been done by the person, and there you can get all the anatomical abnormalities to learn with this.
I absolutely agree. I mean, as a neurointerventionist...
Just, I would like to tell you another thing, that you may throw shoes towards me. First 81 cases of carotid intervention I did without any protection device. Then, even now, every protection device in our country costs over 50,000 rupees.
1 lakh.
Maybe more than that. Yeah,
No,
the newer ones perhaps, at least I used to get for 55,000, and that I have to ask the question.
It's the same cost now as well. It's 55,000.
And ask the patient, can you afford it? Your stent is there, the procedure, hospital, all the costs. And so there, I think that a precise, quick procedure, decide it whether, I mean, if it is a very tortuous artery and all those things, that's a different situation. If you decide without any protection device, you can do it safely. Maybe a few particles going here and there, which you could have seen in the filter device. But is it creating any clinical picture? I mean, clinical symptoms? If not, then it's all right. Accept it.
See, if cost is, I would first I agree.
Mainly, and yes, the cost is a thing, very much important thing in our country. And, so I think the initial experience is very important, that how quickly you can master your catheter.
The procedure, neurointervention, carotid stenting without a distal protection device, I think that's a debatable issue. I think we, as far as possible, we should use the distal protection device.
I think if cost is the issue, we should send it to surgery then. You know, surgery is cheaper, but
it's not the
we
cost.
should not. We should do the best we can.
The risk of stroke.
You see, here I can tell you, the Michelle is also here. Klaus Matthias experience, pre and post, using protection device, the difference was 3.1% to 2.9%.
I think that is even, but I have used both. I did without protection device, but I think even 1% in brain, a minor TIA, I think it's a significant thing for us. So we should favor a protection device always.
Dr. Buckley, please.
Yes. I think I enjoyed your talk. The one problem, you hit the nail right on the head when you say experience is what counts. And if you look at the Medicare database across the United States, you see that the outcomes from carotid artery stenting are not very good because the average person who does it is not experienced. And as a result, there are more people being maimed by an intervention than are being benefited by it, which is why CMS, who pays for things, has not authorized the payment for the treatment of asymptomatic carotid patients unless they're in a trial or a post-market analysis study. Those reasons, and that's because they are only, in most instances, being cared for by people who have a lot of experience. But the issue is when you open the door and you say, we're going to pay for everything, then all the people who aren't experienced go and do it, and it's disastrous. And that's why there are controls on it. I think that applies to almost everything in surgery and anything in interventions. The more you do, the better you are at it. And if you don't do enough of them. In our practice, for example, I have 5 vascular surgeons. Only 2 stent carotids, because we wouldn't stent enough in a year to keep all 5 people proficient at doing it. So we decided among ourselves who would do the carotid stents. We only have 3 people who do aortic endographs because we want good outcomes, and we have 3 people who do them very, very well. And the other 2 do peripheral interventions and do critical limb ischemic cases. And I think that's what you have to do. I think you have to examine your own group and say who does the best at these things. And not everybody can be a jack of all trades, master of none. Because when you do that, the patient suffers.
You're absolutely right. I think what happens is carotid stenting, everybody who thought who will place a stent anywhere in the body can do a carotid stent. And then that is what has led to a little bit of a mess there.
Actually, I think what you say, and I think we take it, and for the audience, the most important thing here is experience. I think no procedure, whether it's carotid or anywhere else in the body, without experience is obviously going to be a disaster. And that's number one. And number two, there is a significant cost, cost factor here in India as well. Whenever, if you were to compare surgery versus carotid artery stenting, the problem in India is that there aren't very many surgeons who do carotid endarterectomies. That's number one. Number two is that everybody who can do an intervention starts doing carotid stenting. And I don't know which one of these is better, not to have enough surgeons to do it, or whether to have everybody, whoever can hold a wire and a catheter, start doing stents in the brain. There is a third thing. You know, Tom Brott, the guy who was a principal and the lead investigator of the CREST trial, he came out with a paper which is just published in the circulation in January of this year. And he said that there is a 3-fold increase in future mortality from strokes after stenting.
No,
3-fold. That's a paper which has been published in
the
circulation.
CREST long-term results have shown is absolutely the same stroke.
This is a subset analysis which has been published 4 years later. This has just been published in the circulation.
I showed you the results of 4 years.
This has been published in the circulation. In fact,
I will have to check. I think I'm a little surprised.
I have it here. Stroke associated with 3-fold increased future mortality in CREST. 11th December. No, this is Tom Brott on the CREST data. This is a subset analysis, and it's been published in the circulation.
What I told you is the published data of up to 4 years. So we can discuss it later.
Yeah, of course.
Okay.
No, that's
And
true. But
you
what
can
I'm
share
trying to
that
say
article.
We need to stop here because
Yes.
I did
Thank
mention to you 10 minutes including questions. Thank you very much,
you very much.
Dr. Vipul Gupta.